polymyositis is a very heterogeneous group of disorders. So many cases which are initially classified as polymyositis are now been, you see over time, it's actually getting reclassified into an anti-synthetase myopathy or an immune-mediated necrotizing myopathy. So slowly this group of disorders is the definition and description is getting a little hazy. But anyway, it's given in Harrison, so let's discuss about it. So as I mentioned, it's a heterogeneous group of disorders. The neurological presentation is similar to any other muscular disorder. It's basically a bilateral, symmetric, and proximal weakness, which worsens over weeks to months. And there can be involvement of the heart, lung, as well as the joints. And just like dermatomyositis, there might be an underlying paraneoplastic association, but the association of cancer is more stronger for dermatomyositis and less strong in polymyositis. So whenever you think of an inflammatory myopathy that is associated with cancer, the first thing that you have to think of is a dermatomyositis. So investigations is your serum CK levels are going to be elevated. So most of your inflammatory myopathies, the serum creatine kinase is going to be elevated. An exception of this is going to be your inclusion body myopathy, which is, it can actually even be normal. And when you do a muscle MRI, it's mainly non-specific features. But when you take it of the quadriceps muscles, there is predominant involvement of the rectus femoris more than the vastus muscles. So this is exactly opposite to what is seen in an inclusion body myopathy. So when you do a clinical exam or muscle MRI for a patient with an inclusion body myopathy, there is quadriceps weakness, but there will be sparing of the rectus femoris. There will be sparing of your rectus femoris, mainly your vastus lateralis and vastus medialis is going to be involved. But in the polymyositis is going to be exact opposite. Your rectus femoris is going to be more involved than the vastus lateralis and medialis. So this pattern is important to know. And when you do the muscle biopsy, you get a perimysial more than endomysial inflammation with a predominant mononuclear infiltrate. So this is a muscle MRI of a patient with polymyositis. So you can see over here, this is a stir sequence. So you can see that there are significant stir hyperintensities involving the bilateral rectus femoris. Bilateral rectus femoris. So if you do a muscle MRI for an inclusion body myopathy, it will be exactly opposite. You'll get more findings in the vastus medialis and lateralis, and the rectus femoris will be spared. So this muscle MRI pattern is just opposite to what you see in an inclusion body myopathy.